Welcome to MAP, the bi-weekly market access podcast provided by Mars Market Access and Pricing Strategy, which is your healthcare consultancy in the German-speaking markets. Mars makes it as easy as possible for you to get your pharmaceutical, medtech, or digital health product to the market and, of course, get the price it deserves. My name is Stefan Walzer. I'm the founder of Mars and a health economist by training and working in the fields of market access, reimbursement, pricing, and health economics already since 2004. And now let's learn about the market access and reimbursement systems around the globe. So inpatient reimbursement in Germany, which is first of all a big kind of question in terms of differentiation also from the budget's perspective. One need to know that in Germany, the inpatient-outpatient setting is clearly separated, not only from a legal perspective, but also from a budget perspective. If we start very briefly with a legal perspective, one also knows that there's the so-called Verbotsvorbehalt in Germany for the inpatient setting, which means basically that all innovative procedures are permitted with the reservation of prohibition, meaning if you have a regulatory approval, a product, a device, or a new kind of procedure can directly be applied and used in the inpatient setting, which is clearly the opposite to the outpatient setting. So let's focus on the inpatient setting before we basically go and discuss the kind of very detailed perspectives, maybe also from a hospital perspective. So if there is an inpatient kind of procedure or product, there are different ways how to get that reimbursed in Germany. First of all, there's clearly the kind of opportunity that a code might already exist. So meaning that in the German DRG system, there is already a code and hence a cost which covers those kind of, let's say, budget already available. And that is basically what everybody can directly check. A DRG browser is available. So that is then also where you need to link the disease based on the ICD code plus the procedure code, which is the OPS code, which is also available in the German system. And both together are basically then ending up in a full DRG. The DRG system itself is updated regularly every year, and that is also based on so-called calculation hospitals, Kalkulationshäuser in German, which means that some hospitals basically provide their information, their data from a yearly kind of turnover, let's say, also from a coding perspective, that also the so-called INEC, which is organizing the inpatient setting, can update and check whether the existing DRGs are adequately funding the procedures in the inpatient setting. So there might be DRGs which are going up or also going down on a yearly basis, again, depending a bit what is being done and in which ways it's being handled. But I think the really interesting question is quite clearly, what if no DRG is really available, or the DRG which exists might not cover the cost of a new procedure adequately? Just keep in mind, adequately means that overall the costs are not somewhere in a range of plus minus 10 to 20% on top of the already existing DRGs, because otherwise the system itself, the INEC, but also health insurance funds, clearly think that that product or that device procedure could be funded through the existing DRG. So just imagine there's maybe a new procedure and a DRG is existing, but the new procedure is significantly more expensive. Forget about at this stage on the evidence. We're coming back to that, maybe also in the discussion with our interview partner from a hospital. But for the moment, we only focus on the cost side. So there is one opportunity once a year, which is end of October, where hospitals can submit a so-called NUB, which is basically an application in order to get an on-top payment. This is a template which is then being available on the website of the INEC, normally around the September timeline, early September, that there's roughly 8 weeks time to update the template, which looks every year quite similar. However, there might be small changes in there. It is advised that such kind of NUB submissions are also distributed by the medical associations, especially obviously if there might be procedures which might help patients not only in one hospital or in individual hospitals, but really across various hospitals. So that's at least something keeping in mind also from a physician's and or industry perspective. In the NUB, there's a lot of more kind of information requested around the procedure itself, on how many patients, very briefly, obviously, how it works, and most importantly, whether the procedure is already adequately funded. Hence, coming back to the question I have just raised a couple of minutes ago, whether the costs are already included in an existing DRG. If not, details need to be given. Once that NUB application is submitted, the INEC, where the submission is basically being targeted to, is evaluating that towards the end of the year. First of all, it's being checked if there's maybe a high-risk procedure as well included. There are special definitions on that, coming back to that maybe as well in a second, which is first of all going to the GBA. They are assessing and seeing if a product is a high-risk procedure, and if not, we're coming back to that special case later, and if not, the NUB submission is going back again to the INEC. They assess it, they check basically that everything is in there, and finally the INEC is deciding, let's say positively or negatively, on the NUB. Important here, a positive NUB means a NUB status of 1, and a negative, a rejection, is basically a NUB status of 2. There are also a NUB status of 3 and 4, which basically means that some information are missing. Important, that information is being communicated on the INEC's website as well by the end of January. And the important part here now is what will happen if a NUB is positive. Does that mean that money is directly floating and basically being paid to the hospital, for example, if they provide and use a new procedure? Not directly. An NUB is just, let's say, the entrance ticket for the hospital to negotiate an on-top payment during the hospital budget negotiations, the annual budget negotiations, which normally start beginning of spring. So the NUB is being submitted, obviously not only for one. Hospitals are submitting a lot of NUBs every year, so they basically as well use that. I think maybe as well a question to our interview partner in a couple of minutes, if the NUB application could also be used as a negotiation mass, because the hospitals need to negotiate their annual budget, the overall hospital budget, with the health insurance funds every spring. So there is a clear incentive to also submit, from my perspective, NUB applications to the INEC every year, that you have as well not only adequate funding, but also maybe some NUBs in your pocket, let's say, for the negotiation with the health insurance funds. Assuming that the hospital is agreeing with the health insurance funds to get an on-top payment, this is then basically being utilized in that year. Importantly, a NUB needs to be resubmitted again every October until the INEC might decide to turn such a NUB in either an permanent NUB, that means that this is existing basically forever, obviously depend how long the procedure is still used and whether there might be new versions or maybe no more used at all, but generally permanent, or if maybe the NUB is no more needed because maybe the procedure is clearly the standard of care is used by the vast majority of patients. Hence, they could also update and devalue the funding within the existing DRG. Very briefly again, what is a high-risk procedure? Because that's also what I have just mentioned very briefly. A high-risk procedure has basically different kind of definitions. So first of all, it needs to be a new theoretical scientific concept. So something really new, so not something like an update or a new version of something, right? It's also important that the medical device or the procedure needs to be of a high risk class from a regulatory perspective. And an NUB request needs to be submitted for the first time by a hospital, and finally needs to be also specifically invasive. Maybe also question to our interview partner in a second, but this is also something which could be checked and reviewed and discussed beforehand within a GBA submission, which I think is especially important for the industry, especially as hospitals do not really like to handle those kind of high-risk procedures, especially if they don't have the full information available beforehand. Keep in mind, if there is a high-risk procedure, the hospital would need as well to further submit the evidence package, let's say, to the GBA once the GBA has identified that high-risk procedure during the NUP submission, and hence that needs to be done in a very rapid way, and that is why hospitals prefer to either have already a written confirmation by the GBA that the new procedure is not a high-risk procedure, or that they have at least already the information available at hand that they can also utilize it if it is a high-risk procedure. But you see, even the inpatient setting sounds in the very first instance, let's say, a bit easier or a bit more pragmatic, especially in comparison to the outpatient setting in Germany. But there are still a couple of things which we need to clarify, I think, in the interview. So let's just see what we'll get out of it, and let's just see the insights and get the insights from a hospital administrator who has a lot of information and experience as well in the last years, so he can also probably speak about the development of the last years. Okay, so thank you, Willi Wöllner, to take part as well in that interview for our Market Access podcast. So very broadly, as you're coming out of the inpatient setting, could you very briefly explain how the, let's say, the system, the coding, the reimbursement system works in a hospital setting in Germany?
Yeah, hi. Thanks for the involving for this, and I try my best to give you an overview about this. Let's start about the financial system or the reimbursement. It's a really complex system in Germany. So one of the most important elements is the annual published DRG catalog, which is published around about in November every year, with the codes for the following year. So all DRGs from the current year for us will be evaluated, so to get an overview what we have done and what we would like to do in the following years. So, and then we have a small introduce a small overview about the reimbursement looks like for the next year with our current medical portfolio. So then we discuss internal the possible portfolio adjustments. So in other words, so is there a possibility to reduction examinations or to expand some other ones? So that is one of the basics. So so we have catalog effects and something like this. And then we have some specials. So like you told new methods or like extra fees. So these are not in the budget for the year. So every year we make a budget together with the insurance fund. So, but this is another part to negotiate with the insurance fund. So we have in the DRG catalog. So you have some OPS. So these are operation and special procedures.
Okay. Yeah. No. I think you bring up already. I think the complexity of the whole system, right? I think it's driven by DRGs, which are, I think, put together by, I think, what is being done, which I think is the OPS code you have just introduced as well, and basically, obviously, the disease itself, so the ICD code. But I think the ICD is given. So generally, I mean, could you maybe just elaborate very briefly if you as a hospital consider OPS codes as really being useful, as some of those, maybe not everybody knows it, but some of those OPS codes do not lead into high reimbursement values in the German DRG system?
Yes, of course. It's in the current billing system, the OPS are a good illustration of medical events. So even if they are sometimes too small, so the OPS is an adaptation, as you told it, of international classification. So we have an overview about our procedures to make a switch to other countries, what we're doing or what doing others. And so the aim is to obtain an international classification to comparison and statistical points of it. So, but some of these OPS codes, these are for the measurability of the performance of every hospital by specifying the codes in the necessary quality reports. There are also a link between the coding and an additional fee for higher price procedures with appropriate medical products. So you can use these codes in the hospital and in the ambulance sector, for example. So these codes are used in both systems, and they will come more and more together in Germany. So the problem is some of these procedures, like examination or a procedure like for a knee or for a hip, you can do it also in the ambulance sector. So they come more and more together to have these patients not in the hospital, maybe for a not this big procedure. So that's really important to have these OPS codes. The problem is there's so a lot of OPS codes, it's a bit too much. So that's maybe a problem. So every year they come more and more and more. We have only the feeling that it's more for statistical, not for to see what we have done. So that's often a problem, maybe. So they are often too big, too many.
Okay, perfect. I think that is giving, I think, a good insight also how and why OPS are, I think, relevant. And I mean, as you also said, maybe there are just already too many, that there might be maybe an efficiency kind of question as well being raised now. You mentioned also in the introduction that there are budget negotiations. I mean, we all know that in any way. Besides the DRGs, I think there are annual hospital budget negotiations.
Yeah.
Could you explain that? How we could really think of that? How do those really look like between hospitals and insurance funds? What are the specifics of those?
It's a funny meeting every year. So in non-COVID times, it's a personal meeting in the hospital between the medical controlling, the commercial administration of the hospital, and on the other side, the health insurance company. After the first personal conversation, the negotiation begins. So, but honestly, even if it's more haggling than a negotiation, because both parties present their points and arguments, and then sometimes we have interruptions from the parties to discuss internally what have the others said. So what can we do? What can we not do? So first of all, you look at the core business of the hospital, e.g. for the what was the performance of the past year, and what are you planning for the coming year? I told at the beginning of the DRG, so that's the basic, and all of this is represented by numbers and made available to both equality. Then we are looking for unique selling points, as well as for one-off effects like special interventions or special patient offer. For example, the revenues for new examination and treatment methods. Fees are not subject to any hospital-specific limitation. So no budget is set up these revenues, which can be interested for the hospital, maybe. So that's a big part of it. So finally, an annual budget is agreed. And it's always a problematic, maybe if you deviate too far from it, or whether they too high or too low. So, but at the end, you have to find a compromise. So I said at the beginning. So it's sometimes like on a bazaar, and because but at the end you need a budget agreement, and so then normally an agreement can be found on site on open issues or subsequently provided by phone or email until the final agreement, which is signed from both sides. So you need a signed agreement, but often you don't find it directly at this personal meeting. Afterwards, they will have a lot of phones and or emails contact, and then at the end, then you will find agreement.
Got you. I think that is that sounds very interesting. As obviously, a lot of times you only get that from the outside view, obviously. So you hear about it, but good to hear the kind of insights as well. I mean, you mentioned also, I think, the potential, let's say, additional funding for potential new procedures. For example, also there's the I think from a legal perspective, paragraph 137E, which is dealing with the high-risk procedures. Could you explain also a bit what that really means, especially obviously from a hospital perspective? And there I'm maybe especially interested to see what is your preparations? What is the need? What the hospital is basically needing if you would foresee such a kind of high risk, call it submission in a way?
Yeah, in particular, this does not represent an accelerated alternative to previous common method or evaluation procedures of the Federal Joint Committee. So at the end, this new or this process for this paragraph, and it is an extension of the decision-making process. We have a lot of problems with this. So because you need a good chief physician in the hospital, because all of these processes is additional work for the hospital staff. So, and this is usually done by the chief physician, and it's very time consuming and has to be calculated very precisely in advance, depending on the risk and possibilities. So currently we have personnel bottlenecks, and these making this increasingly difficult to provide additional support of such programs. But in the end, these programs can be a special feature for the hospital, but it's not a part of for the commercial delegation in the hospital. It's more a part for the physicians, because they have the work with it. So I told the procedure is very, very hard to implement in the hospital, and we have more and more problems with risks and with the data systems and so on and so on. And that is why some manufacturers are already relocated the testing of new methods in other countries, honestly, because the victims are the patients who cannot offer innovative treatments, and also the hospitals which cannot offer special treatments. So this is our problem. So a lot of manufacturers, change this part of intervention, or to bring up these new methods in hospitals. They changing in other countries, because it's often easier to implement these process in the hospital. In our hospital, honestly, if you have the basic, and it's an already new examination and treatment method for the insurance system, then it's okay for all hospitals to offer this. But the starting is too hard in the hospitals in the current time. So we have a lot of other problems, and all of hospitals have really problems with personnel, and you need all your personnel for the core business in the hospital.
Yeah, that's, I think, a very important point, especially in the scarcity of people. I mean, also finding the right people, I think, starts from management going down, obviously, the whole pathway with physicians, nurses, etc. I think very well, I think, summarized. While we're just speaking a bit around reimbursement, codes, etc., this should have been maybe the start, but maybe just bring it closely to the end, right? Could you as well just tell everybody how German hospitals are financed?
How German? Hospital finance. It's based on the principle of the dual financing. So we call it the operating costs of the hospital, all costs that arise for treating patients are financed by the health insurance companies, and all investment costs, however, are financed by the federal state. But currently, as a result, the federal government decide if a hospital will buy it, expand it, or close, or they will finance these investments. But we have the main problem is that we have underfunding of these investment costs from the federal state. So we have investment backlog. So sorry. On the part of the federal state for years. This increases the pressure on the hospitals, and then at the end we expand the services to cover our costs because of these extra budgetary sources. So we're looking for new extra budgetary points like private services, or to offer some new methods, maybe, because I told you these are extra budgetary. So these are interesting for us, but we have a lot of problems in the German system currently. So we are looking for new ways and for new possibilities to finance all our costs. So all people become older and older, and and the costs for treatments rises. That's a big problem in the current system.
Yeah, I think you're just bringing, I think, another important point in there, I think, which is the whole kind of investment cost. And I mean, you know that better than I, but the German legal, or let's say health politicians, have just as well launched the so-called Hospital Future Act, which might be also interesting for hospitals in Germany as well, right? I mean, could you as well, just from your perspective, go a bit deeper what the core benefits and maybe even risks, if you see any, of that Hospital Future Act might be for German hospitals?
It can be a good point, but the digitalization in German hospitals, it's crazy. They're not really good. So Hospital Future Act it can be a starting support for hospitals. So that's the way. So the Hospital Future Act aims to improve the digitalization and the security of German hospitals within a 3-year circle. So we'll be getting a lot of money for this purpose. 3 million euros in the funding are provided by the federal government, and 1.3 billion euros by the federal states or the hospitals. So that's a good support for a lot of hospitals. But at the end, I think the needing is really high. It's not enough. This 3 billion euros. So the main chance primarily exists in the extensive investment programs. So a lot of hospitals already planned investment programs, and now they get a bit support for it. But on the other hand, risk can arise in connection with distributive just because there's no entitlement to funding the hospitals. So and on the other and further risk also arise in the context of ongoing costs after the IT implementation. But in the end, it's necessary to ensure that German hospitals are not digital outdone by international standards. So we are really, really bad in this. And so I'm not really sure. So what can I say? So it's good, and they will help us a bit, but at the end, not for all hospitals. That's another problem maybe. So that the big hospitals, like the university hospitals, get more money, but small hospitals, maybe in the landscapes, but that's. They don't get maybe this money which are needing, which they are needs. So that's maybe a problem for the future. So we will see, and at the end of this year, we will see how many money they get, or what is really in the hospitals. So yes.
Oh yeah, I think that's also, I think, a good end of our discussion. I think a bit provocative as well, which might be politically as well wanted, right? That maybe just the kind of larger or already quite well established hospitals might especially benefit from that Hospital Future Act, and that some hospitals, especially maybe outside of the bigger centers, might be maybe the losers even. We'll see. I think. First of all, thank you very much, Willi. I think that was a very insightful, a very nice kind of discussion. And let's just see how the whole kind of landscape will further develop. Budget differentiation between inpatient and outpatient settings in Germany basically drive the importance, but also the understanding of the two then different systems, and hence the pathways towards market access. We've just heard from one of the hospital administrators from quite a large hospital in the Bavaria region in Germany, how important the various steps are. OPS are important in order to understand, especially then from a health insurance, but also from a negotiation perspective when thinking about a hospital, where and what kind of procedures have been done with the patients. So it's better, or it's basically as well, to understand in which ways patients have been treated, what was done with the patients when they have been hospitalized. And hence, this might, not always, but a lot of times as well, drive into the reimbursement value. Secondly, very important is quite clearly the NUB, the NUB application, which is also helping hospitals in order to get reimbursement, or probably better set funding towards new medical technologies, but also for drugs, for example, if they have as well been used or are being used in the hospital setting. Why is that the case? Because NUB basically allows then hospital to negotiate an on top payments or reimbursement fee for those products, procedures, drugs, when they negotiate the full year hospital budget with the health insurance companies, which always happen in spring of a year. Important as well to mention is quite clearly that not only the direct conversation with hospitals is important, but also the discussions, the alignment, and also the buy-in with the treating physicians. And here, even more important is then probably, especially when thinking about a broader market access than just individual hospitals, that the different physician associations might be taken on board. Important here as well to mention, physicians associations, very similar obviously to the individual physicians, do not only, let's say, react because industries, for example, discussing with them, or maybe as well trying to get them on board, for example, for a new clinical trial, etc. But it is rather important to understand the the importance of the product, the effectiveness, the safety of the product, and even more important, quite clearly, especially when you go into the individual levels, that physicians have had their own experience, because this is also a big driver quite clearly in order to request then the reimbursement, meaning the NUB, for example, at the hospital administration. We've heard hospital administration is especially looking and discussing that with their internal physicians working in their hospital in order to optimize further the armamentarium within the treatment options within the hospital. Having said that, just keep in mind, whoever is listening to that, the NUB submissions are due every October of year. So this is the only deadline you need to have in mind if an NUB is applicable for you. The decision is being made then, let's call it over the late autumn, early winter. That means that the NUB decisions are being made public in January of a year, and then the NUB can be negotiated by the individual hospitals in the spring of that year. And normally they only are applicable for 1 year, meaning that the resubmission needs to be then done. And ideally that is being forced by the Physicians Association. That was an episode of MAP, the Market Access podcast provided by Mars Market Access and Pricing Strategy, which is your healthcare consultancy in the German-speaking markets. MAP is available every second week with a new episode, so watch out. And in case you might have questions, contact me directly and or visit our website on www.marketaccess-pricingstrategy.de.